Hello and welcome back. My name is Ceciel Rooker. I'm the President and Executive Director for the International Foundation for Gastrointestinal Disorders. This session of the Nancy and Bill Norton Patient Educational Series, 30th Anniversary Edition, was a patient panel on constipation and diarrhea. You just watched 4 really amazing videos from Tony Limbo on constipation, Dr. Brooks Cash on diarrhea, and you were able to listen to some patient stories from Erin Slater and Dena Sutton. Thank you all for the time that you took to record these great presentations, and then taking just a few moments today to sort of wrap that up and answer some follow-up questions that have come up from these videos. I'm going to jump right in, and ladies, your stories were so impactful. Thank you for sharing them. One of the things that I did notice is that both of you had sort of dealt with the constipation and the diarrhea for many years. And it wasn't really severe, but you sort of just handled it. So would you say that you were self-medicating, or were you under the care of a physician during that time period?
You mean in the very early years?
Very early, before it got severe.
I actually went to when I noticed a change in my system, I did go see first the primary care, my internist, and then a couple of GI and doctors, and did a few tests. They weren't doing colonoscopies at the time, but they were doing the barium tests. So I did those, and I did a series of blood tests, and everything was normal. So I just kind of ignored it.
Okay, and Erin?
So like I said from my story, I actually, had some mild constipation probably since early childhood, and never really paid too much attention to it, until I, was about 17 and had some more issues with abdominal pain and not really even connecting to constipation, just, having a lot of more pain, and that when it started to interfere with my school life, with my social life, with that kind of thing, I first went to primary care doctor a couple times. They didn't really know what to do, and then I moved on to a GI doctor. So
Great. So Dr. Cash, is that sort of common? Do you see that in your practice where patients sort of just like self-medicate until it interrupts their life? And is that a good thing, guideline, or should they come in earlier?
Well, yes, we do see it a lot. In fact, we see that more, that's more the norm than the exception. It is, and that has to do for a lot of different things, a lot of reasons. It's a little more difficult sometimes to get in to see, certainly a specialist than it might be for a primary care doctor. Often the schedule is 2, 3, 4 months out. But even, talking to their primary care docs, a lot of folks are reticent to seek care for some of these symptoms. They're a little embarrassing sometimes, or maybe even that some patients are really worried about what they might be told, and they don't want to hear, that it might be something serious or bad. And many times, I think it's most just about everybody, and I think I dare say everybody gets some diarrhea every once in a while. Or occasionally some constipation. So we all go through this as human beings. And I think that's also kind of a natural tendency is, well, I've got these symptoms. We'll see how long they last. They'll probably get better. I've been through them, and they've been through it before, and then it got better. And, it's when it starts to increase in its frequency and its duration, and it starts to actually exert a negative effect on people's lives. That's when we start to see people coming in for care.
And as we saw in both of these ladies' stories, they had immediate onset of more severe. So it was something that with Erin, she was born constipated, as she said in her video. She was constipated in elementary school, in middle school, and then in high school. One day, bam, goes to the beach, comes home, and her life has been turned upside down. Dena, same story. She goes out to eat, and just it's like overnight, what was sort of troublesome, but she dealt with it, all of a sudden became unbearable in their life. Is that common, just that sort of fast onset of constipation or diarrhea, or is that something that is a little bit unusual in your practice?
In my practice, in my experience, that's a little bit outside the norm, and it's a little more unusual. It makes you think, what was the trigger? What started, what pushed this over the edge, if you will? Now, I think it's important for us to recognize that there were, kind of chronic low grade, bothersome symptoms, and then the bothersome index, if you will, jumped off the chart. Why did that happen? We don't know. We do see that where people just, they reach a point where it's like, okay, I'm fed up with this, and it's gotten suddenly worse. Recollection is a difficult thing sometimes, but I think we have to take it at face value and say, okay, well, something happened. We don't know exactly what. Sometimes that gives us, especially in the diarrhea realm, I think that gives and lends some credence to antigenic triggers, the immune system, perhaps even inflammation. That's much more consistent with what we think of, and we're thinking kind of the prototypical infection, but immune stimuli, whether it's a food allergen or some other allergen, or stimulator, can be very similar. That's what infections are, is they're immune stimulators. Constipation, a little harder to explain why that could suddenly turn on like that. But, we do see that in some patients, and we're not sure exactly how that should make us differ in terms of our approach. I think when somebody comes in with more of an immediate kind of cataclysmic set of syndromes or symptoms, that we tend to be a little bit more anxious in terms of our workup. And, I think we have to temper that and take things in a hopefully methodical and rational, guideline and evidence driven way as well, before we go, shooting shotguns at all the symptoms and doing a gazillion tests that are probably going to be, as Dena mentioned, largely normal, and then lead to more anxiety, more testing. But you have to take the whole package into account. And it's unusual that kind of symptom onset, but it's not unheard of.
Okay. So, so Brooks, just so you said the patients come in, you see a lot of different, severities, obviously, and you said these are a little bit outside the norm of what you would generally see, but as a rule, when you have patients that are coming in with either diarrhea or constipation, what are some of the things that they should be talking to you about? What are the key points of their symptoms that they should make sure that they don't forget to tell you, whether it's immediate onset or whatever, that sort of thing? What are the things that are important?
So the basics of an interview, and this is just good history taking on the physician's part, and I certainly want to empower patients to share this information if they're not asked. When did the symptoms start in their lives? And when did they get better, such as these sudden worsenings? What makes the symptoms worse? What makes the symptoms better? How can they characterize the symptoms? Is it a burning pain? Is it a gnawing pain? Is it a pressure pain? Is there bloating? Usually we do pain scales we think of pain on a scale of 0 to 10, 0 being no pain whatsoever, 10 being the worst pain that you can imagine. So, where does it fall in that? What's the length of the symptoms in terms of duration? Are they constant? Are they intermittent? And that kind of gets back to what makes it better, what makes it worse. Are there alarm features? Blood in the stool, weight loss? Do symptoms occur at night or wake them from sleep? Is there a family history of GI diseases or other diseases that may have presented like this? Those are the major things that I would want to know. Now, the other things that I think are very important to convey, and I think this is important for our physicians to solicit, is the impact of these symptoms on our patients' lives. And that's not going to necessarily make me do a certain test one way or the other, but it gives me some insight into, we've got to do something about this for this patient. So what are they having to curtail? What have they learned works for them? And what would they like to do? And then finally, the last thing that I would mention is, I will often ask patients, if I could take care of or make better 1, 2, or even 3 of your symptoms, because most people have multiple symptoms with these conditions, what would they be? Or another way to ask that is, what's the most bothersome symptom that you're experiencing? And let's try to take care of that, or evaluate that and then treat that. Sometimes you have to do things in a stepwise fashion. But those are the things that I would love to have a patient come out and tell me. Sometimes my patients come and that's exactly what it is. And sometimes I have to dig a little bit. But I think it's important for clinicians to know that those are the types of questions. And I'd love to hear what our colleagues say in terms of what they'd like to hear from their clinicians as well. But I think that's, if I was a patient, that's what I would want to share and also have asked of me.
I think that is fantastic, and you're reading my mind. I actually was going to ask the ladies that. So Dena, let's start with you. What sorts of things do you wish your doctor had asked you in the beginning, or what are some things that you discussed with your physician that you thought were really helpful in your journey over the last 30 years?
Um, I really can't remember my first visits and what was asked. So I don't want to, go back on that. But I think that what now I find is that over the 30 years, because I have this label, IBS, that I get very little questions in depth. It's like, okay, you have IBS. You've done all the tests come out negative. There's nothing that shows up. So, okay, let's manage it. And then they throw things at me. We can try this, we can try this, we can try that. Half the time I've tried almost everything already. So, I feel like it's become perfunctory. The visits become perfunctory. They're just, okay, you have IBS. Did this work? Does this work better? Sometimes I get asked, what's the worst thing that you experience? But I think I would like, I'm not always sure what questions would be relevant in the sense of, you were talking about alarm features. Those are, obvious, but there may be other issues like the patterns or, what happens when you do this or when you do that, or, how can you tell what food bothers you, for example, because it could be within 10 minutes or it could be 2 days later. So I would hope that the physicians would ask those kinds of in-depth questions to dig a little more about the pattern of my conditions. And I feel like so much of it, I mean, part of it, I know doctors are under pressure from insurance company to spend, not to spend a whole lot of time with patients. I know that doctors are swamped. It takes 6 months to get an appointment with some of the GIs in, around my area. So I'm sure that they are under a lot of pressure. But sometimes it's frustrating. You walk in 10 minutes later, you're out and you feel like you haven't really discussed the issue.
Makes so much sense. And you're right. Healthcare today, the visits, they're very tight, and making sure that we're asking those right questions is so important, and really getting to the meat of it. Erin, how about you? What are some things that you would wish either maybe they did and this is a positive thing, or maybe you wish
Yeah.
they did?
Yeah, so I actually was talking a little bit about this before. I started having symptoms right before turning 18. So in the very beginning, they were saying, well, we can't send you to an adult gastroenterologist. You have to go to a pediatric gastroenterologist, which of course is a longer wait time and not really. They're probably used to younger kids. So it was, not the greatest first experience. And he was actually probably a very good doctor. It just wasn't the right doctor for me. And I actually ended up, because he said, can you point to where it hurts, which is my problem. I had pain. I didn't even think about constipation. I know that's such a strange thing to say, but because I was always sort of constipated, it was just my life. I had a lot of pain. So I pointed, and anatomically, your stomach and the transverse to descending colon are very close to each other. So he thought I had more of a stomach pain rather than colon pain. So I literally started from the top down. So over the next couple of years, it was just top down. Starting in the stomach and small bowel, and finally getting down to colon. So I wish that doctor, and maybe even the next couple of doctors, had asked me what was my main symptom. I mean, I was saying I'm in pain. Okay, I was diagnosed with lactose intolerance. Why would that be pain? No. So it wasn't, it just wasn't clear that they were hearing what I was saying. And my last doctor actually did spend the time, did listen, which was, it's surprising that it takes that long. It took 5 years to get to somebody that would actually listen to what my symptoms were, and that's when I finally got help.
Yes. So, and I think we hear that a lot. That the listening skills and really and truly asking the right questions is so helpful in the communication. Now, I've noticed with both of your stories, this is chronic, right? This is truly chronic. You've had this your whole life.
Yeah.
And how has not only your illness evolved through the years? Erin, you talked about a lot with yours, right? You started with constipation, you added some abdominal pain to that. And so we sort of have chronic constipation, functional abdominal pain syndrome, and IBS-C sort of all layered inside. So that's, I understand the evolution of yours, but you're welcome to expand on that a little bit more. I know because there was some food stuff that you mentioned to me before. And then, and Dena, also with you, how has your disease progressed throughout this 30-year journey, or has it? Or has it remained consistent for 30 years?
Um, Actually, it's gotten worse, I think. It does go up and down depending. It's like I try something that works for a while and then it stops working. So then I have to try something else and then that stops working. And so when it stops working, before I try something else, I go through a period when it gets really bad. And then something else kind of works for a while and then, and then again, it's kind of stops working. I the other day I made a list, or a few months ago I made a list of everything I've tried, including meds, approaches, everything. I had over 70 items that I said I even tried, either approaches, like acupuncture, for example, as an approach, or meds, both allopathic medicines and alternative complementary medicines. I've tried out just about everything. Just about. I know there's some things I haven't tried, but it fluctuates, and within that fluctuation there's also usually a week by week pattern. So I now see specialists in two different medical centers because they have two completely different approaches to. I see somebody at Cedars at the motility clinic, and I see someone at UCLA with a gut brain connection. So I have trying to, and I see a nutritionist. So I'm trying to get the best of everything. But I've done all of this before. I've seen somebody at the motility clinic for like 4 or 5 years now, and I've been at UCLA on and off with different gastroenterologists since the very beginning. The first GI I ever saw was from UCLA. So
So,
when I feel that physician can help me anymore, then I try something else.
okay. So I wanna circle with Dr. Cash about the medications not working and then stopping and starting working. But before I do, just really quick, Dena, does your team, the nutritionist, the motility specialist, and the gastroenterologist at UCLA, do they work together in sort of a multidisciplinary approach, or are those all siloed interactions? I'm just curious.
The nutritionist works with the physician at UCLA. She's at UCLA and they work together. The
Okay.
motility clinic is separate, but they all see my chart because everything is on these portals. So I'm sure they see it. They haven't talked. I saw the UCLA doctor after most recently for the first time. So she already knew that I had been to Cedars. I don't know how much the Cedars doctor knows about what she's doing. I didn't want to offend him by saying I'm going to somebody else, so I haven't said anything. So,
Understood. So Dr. Cash, what Ms. Sutton was saying that she tries something for a while and then it just stops working. Is that common with diarrhea patients or even with constipation?
It's common with IBS,
Okay.
and it's common with other disorders of gut-brain interaction. What we used to call and some still call functional GI disorders, but we're trying to get that new nomenclature in place because it really is a disorder of gut-brain interaction. And there are a multitude of different causes of these disorders, some of which we are aware of and have become very aware of them. Others of which we are just still discovering, and that's kind of the, I don't want to make it sound like it's fun, but that's the challenge and the kind of the exciting part because of the discovery and then the ability to hopefully help patients when we do discover something new. But so yes, the answer is absolutely, it's common. I'll have patients who will do very well with the therapy, sometimes for months, if not years, and then something changes and we don't know what. We have such poor ways to accurately measure what's happening in the gut in terms of motility and secretion and sensation, and there's a lot of other things, and the interactions. We have ways to measure those in some patients and in some scenarios. Many of those scenarios are more investigational, more heavy research. We don't know how clinically relevant they are, and I'm talking about things like barostats and marker studies and that sort of thing. Pain remains a very difficult thing to measure. one person's pain is another person's discomfort, is another person's bloating, is another person's normal. So, you know, it's a really tough group of symptoms to try and tease out. And we will see medicines either lose their effect or even start to have some side effects that we didn't have in the past. And we don't know why that occurs. And that's kind of the $10,000 question in terms of our patients. You know, why do these symptoms start? What makes them get better? And you know, there's not a single magic bullet. And I think that's really the key to Dena's story is, you know, we have to keep not necessarily rotating different therapies, but we have to keep thinking outside the box in terms of different causes. And there is no rule, even though we love to have in medicine, you know, an approach where it's you know, it's very Oslerian or Occam's razor, you know, one cause for a multitude of symptoms to explain the syndrome. But there are certainly circumstances where there are multiple causes of different symptoms in all of these conditions. You know, we can't avoid eating. We've got to eat. We're recognizing that dairy or diet plays a significant role in these symptoms. We have to move. Mobility and motility go together. Rest, sleep, emotional state. You know, there's just so many things that confound our gastrointestinal tract and its workings that it's often difficult to tease all that out.
Totally appreciate that. Thank you, Dr. Cash. Erin, how about you? How's your disease evolved or shifted and changed through the years?
Yeah, so I th I think that a lot of people have similar stories to mine where they maybe not exactly the same, but where they have a lot of abdominal pain, um, and they might associate that with constipation or not, and don't want to um, think about that they have some stressors in their life. And not that it's caused by the stress, but that the stress exacerbates the symptoms. And that was me. I was 17, 18, when it started, and I just wanted to go off to college and be a normal, college person, and travel and that kind of thing. And it was almost as if I went to bed every day thinking, well, tomorrow it'll go away. And I think I did that for years until I admitted to myself, something's got to change. The constipation is there and it's still there. It hasn't gone away. But how you deal with the symptoms, and I'm not saying that, oh, buck up or that kind of thing. But you have to admit to yourself that there are multiple therapies, multiple ways that, you can treat pain. There's physical pain and it's physically there, but there are a lot of different ways to treat that pain, not just with, say, pain medication, but, a lot of ways to look at your symptoms and sort of kind of walk yourself through it. So I do a lot better with the pain, and I have been for years, and that's fantastic. I get to live my life and enjoy my job and enjoy my free time. And but I do still have IBS with constipation, and I am lucky enough, and I think I did it on purpose. I chose a field where I have some um, leeway as to what I can do during the day. So if I have to be stuck in the bathroom for 45 minutes because I'm getting spasms and that kind of thing, then that's just how it is. And after those 45 minutes, I go and go about my day, and it's still there. It's just it I just have to deal with it. So yeah.
Yes, and I think that learning to manage your symptoms. Oh, I think you've lost my camera. I apologize
Oh
to
yeah.
those of you online. But hopefully you can hear me.
Yes.
So I think that, really that management, right? When you're looking at chronic illness of any kind, whether that be a GI condition or even a heart condition or diabetes or anything that is chronic that you have to deal with every day, it's learning those skills. creating a good healthcare team, having what you need and all those resources. And as you said, looking at some of those stressors that might be causing some issues as well, and looking at this holistically. And so that's a great way to sort of to wrap us up here. Any last minute comments, Dr. Cash? Anything last parting words with the patients? Not only these two wonderful ladies who've been so kind to share their stories, but also those at home, and dealing with diarrhea and constipation.
Sure, and I want to thank Dena and Erin as well for taking the time and also having the bravery and the the chutzpah, I guess, to share their stories, because I think putting a face to these symptoms is really critically important, and I certainly appreciate what they did. And in terms of things for our viewers, don't suffer in silence. These are among the most common disorders that a primary care physician will encounter. They may not, and this is nothing, I want to, again, I respect my primary care colleagues. They have to have an incredibly broad and deep knowledge. And, I once was a primary care provider, and now I'm a specialist, and I can't go back, unfortunately. But, don't suffer in silence. Ask for a GI referral if you're not getting better or getting the care that you think you need with regards to these conditions. They absolutely can be managed in many cases. We are moving towards, our practice is evolving to being able to provide more integrated care, which you were getting towards. I think that's going to be really the model for many, especially academic programs, but also even out in the community, having dietitians and psychologists and other specialists who are available to help patients manage their symptoms, because it's not all about pushing medicines and pills. It's a lot about education. It's a lot about lifestyle modifications. It's sometimes about medicines and different treatments, but there are many aspects to the care of patients with these disorders that I think are going to improve their quality of life in the future. And, they're definitely livable. But if you can find somebody who understands the conditions and has the ability to adequately treat the conditions, it certainly can improve quality of life. And that's really the key thing that I want to convey, and make sure that those watching know that there is hope, and that they should seek out that hope and seek out that care and not suffer in silence.
Fantastic. Thank you, Dr. Cash. True. Such truth in those words. You are definitely not alone. Those of you at home. How about you, Erin Slater? Just any last words for your fellow sufferers of constipation?
Yeah. It's something that a lot of people have and don't talk about, and it might be something to you that, well, if you're watching, it's probably something that does affect your life, enough. But talk to friends. Don't, if you're feeling like you're getting out of social situations, or not living your life the way that you want, talk about it. And again, just don't suffer in silence. Find somebody to help.
Absolutely. And I know for me personally, Erin, you and I share a little bit of a similar story, with me also having chronic constipation from a very young age. One of those things that, I didn't realize is that, making sort of those suggestions, to your friends and saying, instead of going to dinner, why don't we go take a walk around the park? Let's get, let's go walk a little bit. That helps with my constipation, gets me moving, and also has to, avoid, any sort of eating scenarios where that might be awkward for me, or something I can't participate in. So making suggestions like that is definitely something, and talking to your friends and saying, guys, that's not really a great option for me. So how about this instead it's always great to do those types of things. What about you, Dena? What sort of parting comments do you have for our audience today?
Well, I want to, back up the idea of talking to friends. For me, it's always, the problem is always about eating out. And, my friends go out to, we all go out to dinner a lot. Most of us are retired, so we don't have small children at home, so we want to get out. And a lot of times there are places I just can't find anything to eat. So I tell my friends up front, I have they all know now, but that I have this GI issues and I can't eat everything. And, I'll just hope that they're not embarrassed by me asking the waiters a million questions before I order something to eat. Um, but it's like I've got to suck it up and do it because otherwise I'll be sick. So I have to do that. The other thing is in the last few years, I connected with a lot of people on Facebook. And I hate to say it because right now Facebook is not looked as a positive platform, but there are many, many, many groups on Facebook of people who have IBS, who have diarrhea, who have constipation, who have other GI issues, who have SIBO, whatever. And I've connected with them. And so we exchange information. Sometimes I hear about something that they've tried that works. So I share my own experience because I've tried so many things. And that's really been helpful to be able to exchange information with other people who are going through the same thing that you are. And recently I found out a good friend of mine has an IBS issue as well. So we started sharing information, going to the same doctor actually. And so that's always really helpful to be able to share that. And I have to say, I'm very lucky that my husband is very supportive and, he listens. He allows me time to run to the bathroom if I have to. So, and so if you have a support system, that's also a really good help.
Absolutely. And you touched on a couple key things just to mention to everyone at home. One is that, we had an advocacy event earlier this year in March. And one of the topics that we covered was the use of support groups online and in person. And we were able to speak with some wonderful guest speakers who were able to talk to us a little bit about how to find those support groups and what are some things to look for, what are some things to how you choose the right one for you. So for anyone at home that's interested in learning more about Facebook support groups, check out the IFFGD advocacy event for 2020, and you can learn a little bit more about how to do that. And then also with the support system, that is so true. And IFFGD did have our first Ally Awards this year, and where people could really recognize people in their support circle. And there were doctors nominated, nurses nominated, husbands, wives, children. And really and truly where we find our support is it's all relative to what we are going through individually as the patient. And so that was really enlightening for us. And please, Dena and others at home, if you have a strong support group, think about nominating one of them for the Ally Award next year. We really do enjoy seeing those stories and being able to give back to these people who give so much to us. Again, all three of you, thank you so much for taking time to sort of circle back with us and have this conversation. For those of you at home, again, we have Dr. Brooks Cash here with us, who is a professor of medicine and division chief. Thank you so much for taking time not only to record your presentation on diarrhea, but then circle back for this. And then we have Erin Slater, who is actually a member of the IFFGD Board of Directors as of this year, a longtime advocate for those with GI disorders and a patient from birth. Thank you so much for your time and your service to your patients in the hospital system where you work as a dietitian. And then Dena, thank you so much for taking time, not only here, but in other instances. IFFGD has called upon you to share your story, and we appreciate your willingness to do that with the FDA and then also with this program. So thank you all very much. And for those of you at home, we hope you enjoyed this session. Please reach out to us at iffgd@iffgd.org if you have any questions, comments, or suggestions for this or other programs in the Norton Educational Series.